cutting and rotablation in different types of calcifications? Because this depends on the experience, or you need an IVUS to classify the calcification to see it properly, because there's some speculation about the left main, some speculation about extension of the calcification. Sometimes it's short, it's not long. So when did you decide to?
Now, if you place IVUS in this patient, 82 years old with diffuse calcified disease, you will find plaque at the Roma and calcification for the distal LED to the ostial left main. It's true. But this is a problem of IVUS. What to do when you have this scene? We know this by experience. So the advantage to do IVUS is the following. When IVUS evaluation, IVUS assessment, show you that you have a concentric calcified lesion, 360 degrees, this is the right indication for rotablator. In the opposite, if you have an arc of calcium with, in the opposite part, a non-calcified part of the vessel, normally the balloon could do the job without rotablator. This is, I think, one of the most interesting indication for IVUS, to look at the anatomy of the calcified lesion. I think we have to move on.
My colleague just tells me when it's difficult due to the distance for him to follow me, and I just step, she gets closer to me, and then we go on. Pull a little bit. Okay. When you see that the guiding catheter is getting out of the ostium, you have to pull on the wire to get it back in. So the burr is coming. Tiens un peu plus, pull a little bit.
This is a part of the procedure.
The part where you need a big pull on the wire.
One operator advances the burr, and particularly when we arrive in the artery,
Martin or Peter, when you have this kind of long lesion to rotablate, you have a special preparation, special cocktail, what is, because normally the risk of distal embolization is higher when we have this kind of long lesion.
So at our institution we have a mixture of verapamil, nitrate and heparin in the flush.
Okay.
But I think maybe the more important thing is not the flush, is to take your time. I always say you can never do a rotablator too slowly. You just have to take your time and not rush and let the coronary recover each time. There's another important factor here. If you could just come down to my finger, and that's, so Didier has placed the advancer knob about 2 centimeters forward, because that technique of getting the burr to the coronary sometimes leads to a store-up of energy in the burr, and if you have it in its fully retracted position, as you spin, it'll jump forward. So what I'm sure Didier will do now is to move the advancer backwards until you see the burr moving, and then you know that when you spin, it'll be nice and stationary, and it takes all the tension out of the system.
Martin, you said you're going to advance slowly, but what in addition are you going to watch? You have selected the rotational speed at 180. If you go too slowly, it may impact on a plaque. May that induce a reduction in the RPMs?
I have to say, I think, in the old days we used to call out the revs, and whether there's a fall or whatever. I think that's old-fashioned.
So we saw that it was a little bit difficult at the first part of the burr to cross the first lesion, which tells us that it was maybe more calcified and tight than we thought. And one very important thing is to keep on rotating while you are crossing the lesion and not stop the rotation just after the lesion, because you can get stuck and it can be very difficult to get back the burr. So I stopped the rotation once I got back to the initial position.
But I'd say there are two things. First of all, you listen, and you can hear as you engage the plaque. Secondly, you feel, so you can feel any resistance, and you can, of course, see any falling. But as long as you're continually advancing and retracting the burr, then really you shouldn't stall or big reduction, as long as you're continually moving. And the thing I'd say to Didier now would be, okay, he's gone through the lesion, but now to do it as slowly as possible. Because
Can I ask? Martin, as Didier is having his second run of phrasing, this time Didier advanced the bar much slower. The first time he did it, according to your opinion, is this what you would have done in your practice as well, a quite quick passage of the burr, or would you have done it in this similar to the second way?
Clip on the end. I must say I probably would have done it a little slower with just to make sure you're not dottering. It's very easy to dotter these lesions. You have to let the device do what it's designed to do, which is essentially to ablate.
And in fact, I didn't apply too much tension on the burr, so when it was able to cross, it crossed, but it wasn't due to the force I applied to the device. So now I have switched the rotation mode to the Dynaglide, which is close to 60 to 90,000 rotations per minute, and this can allow a safe retrieval of the burr. So now, Martin, maybe we can have a film to see what we have done so far.
And I would usually make sure we fill the patient up with a bit of nitro at this stage.
Okay.
While you're busy, I would like to ask Jean, the right has been treated with a bare metal stent. What is your feeling of treating the LED with a drug-eluting stent? Does it make sense?
It's difficult situation because on one hand we have a long lesion to treat, and it should be certainly covered by at least one very long stent, 38 millimeter, or too long, or two stents, and we know the risk of restenosis if we use a bare metal stent. On the other hand, is the elderly patient is on Coumadin. Nice. So if we place a drug-eluting stent, we will have to talk about the treatment post-procedure with the combination of dual antiplatelet therapy and Coumadin, which is in this elderly patient could be risky. This is a difficult point. Personally, I will move for a drug-eluting stent because it's a long lesion and the risk of restenosis will be high.
High pressure.
14.
So we have taken a 2.5 by 20 millimeters conventional balloon.
So this Didier is a 20 millimeters, so we can assess with the balloon the length of the total length of the lesion, which should be longer than 30.
Exactly.
Yeah.
The nice part was the way this balloon so easily tracked down this LED.
And that's what will be my next question. What about the feeling with the balloon? There was no resistance?
Friction. No friction. It was quite simple and to get cross the lesion, through the lesion.
So now you inflate in the proximal part of the lesion. What's his pressure?
14.
And here it is clear that the segment that has been treated is certainly 40 millimeters long.
Okay. We can use the same technique to size the length of the lesion, the proximal lesion. 20.
And then the question is, Didier, Martin, the size of the stent. This is a 2.5 balloon, is correct?
2.5, yeah. Correct.
Yeah. You know, the one thing, once you've ablated a lesion, is I think to treat the coronary with a degree of respect, and I wouldn't oversize the first stent. And I personally would start with a 275, large enough for this vessel. I guess now would be the time that I personally would change this wire, because it's not a great wire to stent on, Didier.
So we're going to take back the fine cross microcatheter to make the exchange of the wires. Okay. So we're going to take a BHW extra support wire.
Yes, we can just have a stop, because this is important point of the procedure. They did the balloon inflation on the rotor wire, which the support of the wire is very low, it's very poor. So it's a reason why before starting the stent implantation, they will change the rotor wire for an extra support wire in order to facilitate first the crossing of the lesion by the stent, and then to have a good stability of the wire. You want to?
For the sizing the balloon and the step-by-step approach for the ballooning. Yes. You start by 2.5, and as if that is. I mean, you choose a smaller balloon at the beginning, but yes. After, and then upsizing according to the friction, or according to what you are going to see in the stent booth, or I mean, because or you just ballooning and then you put, because you can see the cross section.
Sorry, but
okay.
What I have to do? Go on. Sorry, I will ask you answer to your question. One more.
Can you?
Yes, go ahead.
Okay, go ahead.
What happens? It's not working.
For me, I will do IVUS, but John doesn't like IVUS. He is very expert, and he can do a stent booth in a cath lab. Is not using IVUS so frequently, but he can use IVUS in such patients, to see what's going, because it's a cross section sometimes. But he knows that this patient is having a concentric calcification. That's why he's playing the game with a concentric calcification till the end. That's right.
Yeah. So what we do, we match, of course, the size of the vessel to the size of the guiding catheter. We're using the QCA. You can use also the visual estimation. The third point is that there is no proximal LAD less than 3.5. So at least a mid LAD like that should be a 3 millimeter vessel, at least. This is the other basics. And so, of course, if you want to be sure that your diameter, you can use IVUS. But again, even if IVUS show you 3.5 millimeter vessel in a mid LAD, do we choose the 3.5 millimeter stent? Certainly no, because the risk of dissection distal to the stent will be high. So that's a problem of the IVUS can give you a real and precise diameter of the vessel. But when we have a diffuse disease and calcified and long disease on the vessel, you have to undersize the size of the balloon and the size of the stent in order to prevent the distal dissection. So it's always a balance between the optimal stent deployment and to avoid the potential.
Actually, I totally agree with you, John. Just last week, and from this region of the world, we have a lot of diffuse disease and thin vessels. And you will be surprised that if you do IVUS, you will always see your vessels much larger than you think.
Yeah.
Last week, I did a case exactly like you mentioned, John. The vessel looks 2 millimeter only. But when I did IVUS, this vessel was 3.5 millimeter.